The last lesson in the section of RLD will cover connective tissue, immunological, metabolic, traumatic, and therapeutic causes of restrictive lung dysfunction. The first category of connective tissue disorders that present as restrictive lung dysfunction are rheumatoid arthritis, systemic lupus erythematosus, scleroderma, polymyositis, and dermatomyositis. Rheumatoid arthritis is a chronic inflammatory process that results in progressive destruction of joints, and when the lungs are involved can cause pneumonitis, interstitial fibrosis, pulmonary nodules, pulmonary vasculitis, obliterative bronchiolitis, and increased incidence of bronchiogenic cancer. In addition to lung involvement, chest wall compliance may also be decreased significantly. Diagnosis of RA is set by the American College of Rheumatology and must include 4 of the following. 1 hour of morning stiffness present for at least 6 weeks. 2 inflammatory arthritic manifestations in 3 or more joints for at least 6 weeks. 3 swelling of the wrist, metacarpopharyngeal or proximal interpharyngeal joints for 6 weeks or more. 4 symmetric joint swelling. 5 radiographic evidence of changes in hand or wrist joints. 6 rheumatoid nodules. And 7 presence of serum rheumatoid factor, RF. Use of radiography, which may show pleural thickening or effusions or rheumatoid nodules in the upper lung folds, ultrasound and MRI are often used to confirm diagnosis. Patients may present with interstitial fibrosis, which has a honeycomb appearance on X-ray, pulmonary hypertension and vasculitis, pleural pain, and progressive dyspnea. Treatment consists of corticosteroids, immunosuppressants, TNF blockers, and nonsteroidal anti-inflammatories, or NSAIDs. Systemic lupus erythematosus, or SLE, is a chronic inflammatory connective tissue disorder which involves the immune system and is mostly seen in women ages 15 to 45. It can involve the skin, joints, kidneys, lungs, nervous system, and heart. Pulmonary involvement occurs 50 to 90% of the time, with pleurisy often with recurrent pleural infections, acute lupus pneumonitis, and diaphragmatic weakness being the most common. Another form of SLE may occur with medications, such as procainamide, hydrazoline, hydrochloride, procalcitol, penicillamine, isoniazid, and hydantoins, and is treated by stopping the medication and administering steroids or plasmapheresis. The American College of Rheumatology has set forth 11 criteria that patients may exhibit, and 4 must present serially or simultaneously for a diagnosis of SLE to be made. 1. Abnormal titer of anti-nuclear antibodies, ANA. 2. Butterfly or malar rash. 3. Discoid rash. 4. Hemolytic anemia, leukopenia, or thrombocytopenia. 5. Neurologic disorders such as seizures. 6. Non-erosive arthritis of 2 or more peripheral joints characterized by tenderness, swelling, or effusion. 7. Oral or nasopharyngeal ulcerations. 8. Photosensitivity. 9. Pleuritis or pericarditis. 10. Positive lupus erythematosus cell preparation, anti-DNA or anti-SM test, or chronic false positive serologic test for syphilis. 11. Renal disorder with profuse proteinuria or excessive cellular cast in urine. Patients may present with fatigue, weight loss, pleural rub on auscultation, and chest X-ray changes consistent with effusions, pneumonitis, or impaired diaphragmatic function. Treatment consists of NSAIDs, corticosteroids, antimalarial agents, and immunosuppressants. Scleroderma appears as a progressive fibrosing disorder that causes degenerative changes in skin, small blood vessels, esophagus, intestinal tract, lung, heart, kidneys, and the ends of the joints. It is 4 times more common in women than men, but the cause is unknown. Within the lung, scleroderma appears as a progressive diffuse interstitial fibrosis in which collagen replaces normal connective tissue. Scleroderma is often classified as limited or diffuse. Limited cutaneous systemic scleroderma is also called CREST syndrome and has a close relationship with pulmonary hypertension. CREST stands for calcinosis, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, which is hardened fingers, and telangiectasia, which are dilated small blood vessels. Diffuse scleroderma has more widespread and rapid skin thickening. Both show a high evidence of interstitial pulmonary fibrosis. Pulmonary function tests will exhibit signs of restrictive lung disease with very decreased DLCO. Blood tests will show increased erythrocyte sedimentation rate, ESR. Urinalysis will show proteinuria. GI series will show esophageal dysfunction, and skin biopsies will show fibrotic changes. Since there is no effective cure or drug intervention, supportive care is aimed at treatment of symptoms. Lungs transplantation may be an option if other organs are not involved. Polymyositis and dermatomyositis are both systemic connective tissue diseases, with polymyositis showing muscle weakness and pain and pulmonary symptoms of respiratory muscle dysfunction and aspiration pneumonia. Dermatomyositis generally shows up as inflammation and skin changes. Tests include muscle biopsies, EMGs to measure muscle activity, and MRIs. Treatment revolves on resolving pulmonary issues, with corticosteroids being the treatment of choice. Two immunological causes of RLD are Goodpasture syndrome and Wegener's granulomatosis. Goodpasture syndrome is an immune complex that is characterized by interstitial or interalveolar hemorrhage, glomerulonephritis, and anemia. It is caused by anti-glomerular basement membrane antibodies, or anti-GBM, that react with the vascular basement membranes of the alveolus and glomerulus. Diagnostic tests include evidence of anti-GMB antibodies, and the overall prognosis is very poor. Treatment includes plasmapheresis and immunosuppressive therapy to lower anti-GBM antibodies, and cyclophosphamide with prednisone is the regimen of choice. Wegener's granulomatosis is a multisystem disease that presents as vasculitis in the upper and lower respiratory tracts, glomerulonephritis, and small vessel vasculitis, often leading to necrotizing granulomas and ulcerations in the nasopharynx and paranasal areas. Blood tests such as an anti-neutrophil cytoplasmic antibody, or ANCA test, will be elevated. Urinalysis will detect blood and protein, and tissue biopsies will reveal granulomas. Chest x-rays may reveal pulmonary infiltrates or cavitation or lesions. The treatment of choice is cyclophosphamide and can produce a partial or marked improvement in 75 to 91% of patients. Without treatment, death is usually rapid. The metabolic disorders of obesity and diabetes may also affect the lungs. Obesity is defined as a 20% or more increase over ideal body weight. This extra tissue requires extra oxygen and produces extra carbon dioxide, and extra soft tissue on the chest wall decreases compliance of the thorax and increases work of breathing. Patients may demonstrate hypoventilation syndrome and VQ mismatching with hypoxemia. Treatment may be complex but can be a combination of dietary changes, increased activity, and counseling. Patients may also be tested for sleep apnea and treated with CPAP, weight loss, avoidance of alcohol, and dental devices. Surgical interventions such as gastric bypass or lap band are reserved for morbid obesity. Diabetes mellitus results from abnormal carbohydrate metabolism due to inadequate insulin secretion and subsequent hyperglycemia. Pulmonary manifestations are an increased incidence of pulmonary infections and tuberculosis. Diffuse alveolar hemorrhage has also been reported due to inflammation and necrosis of the pulmonary capillary endothelium. Juvenile diabetics have shown a decrease in elastic recoil in the lungs and decreased lung compliance, causing a decreased TLC. Non-cardiogenic pulmonary edema may also be a risk of uncontrolled diabetes and subsequent ketoacidosis. Diabetes is diagnosed with fasting glucose test or oral glucose tolerance test. Type 1 diabetes is further diagnosed with zinc transporter 8 autoantibody ZNT8AB test. Treatment includes insulin or dietary changes and medications to lower glucose production. Traumatic causes of RLD include flail chest and lung contusions, pneumothorax and hemothorax, and thermal traumas, usually due to inhalation injuries and direct burn injuries to the thorax. The leading cause of blunt traumas are motor vehicle accidents. Patients may have rib fractures resulting in shallow breathing due to decreased chest wall excursion and lung expansion, or flail chest in which two or more ribs in a row are fractured. Flail chest patients will exhibit paradoxical movement during the respiratory cycle, contributing to decreased lung volumes and VQ mismatching. Chest x-rays are the diagnostic tool of choice, but CT scan and MRI may be used if lung contusions are suspected. Treatments include pain control and mechanical ventilation and supplemental oxygen for support of flail chest, particularly when respiratory rates exceed 40 breaths per minute and VC decreases below 10 to 15 milliliters per kilogram of ideal body weight. Patients need aggressive pulmonary toilet to prevent incidence of pneumonia. Penetrating wounds such as pneumothorax, hemothorax, and pulmonary laceration may also be the result of motor vehicle accidents, shootings, or stabbings. Pneumothoraxes may be open, which means air in the pleural space communicates freely with the outside environment, resulting in the patient being unable to maintain a negative pleural pressure. Subsequently, the patient will be unable to move air into the affected lung, resulting in decreased lung volumes and lung compliance, VQ mismatches, and impaired gas exchange. A tension pneumothorax results when the air that enters the pleura cannot escape in the environment and causes interpleural pressures to increase rapidly and is considered a life-threatening emergency. The involved lung collapses and patients will experience mediastinal shifts with decreased cardiac output leading to hypotension and shock. Hemothorax is the presence of blood in the pleura, which compresses the underlying lung tissue and prevents lung expansion. If blood is not evacuated, it leads to non-elastic fibrous tissue, which can form a restrictive pleural rind. Pneumothorax is diagnosed with chest X-ray and ABGs are drawn to determine respiratory involvement, and transthoracic aspiration effluence confirms hemothorax. Treatment of pneumothorax includes airtight sterile dressing over a sucking chest wound, chest tubes, and mechanical ventilation and oxygenation as patient evaluation dictates. Hemothorax is evacuated with chest tubes or surgery for massive bleeding. If fibrothorax develops, decortication may be required. Exposure to fire and smoke are the primary causes of thermal traumas. Usually there is a direct injury to the upper airway resulting in laryngeal and tracheal edema, with laryngospasm and bronchospasm common findings. Second, there is damage due to carbon monoxide inhalation, which causes severe hypoxemia, as the carbon monoxide binds to hemoglobin 200 to 300 times faster than oxygen. And thirdly, pulmonary dysfunction is caused by inhalation of noxious or toxic gases, resulting in surfactant inactivation and chemical pneumonitis. Chest X-rays are the main diagnostic tool to investigate intraalveolar infiltrates, and ABGs with co-oximetry to evaluate carbon monoxide poisoning. Pulmonary treatments include oxygen, bronchodilators, humidification, and pulmonary hygiene. If ventilator support is indicated, patients may use high-frequency ventilation and PEEP, and sometimes hyperbaric chambers may be used. Therapeutic interventions may also lead to restrictive lung dysfunction. These include both surgical and pharmaceutical therapies. Surgeries may lead to post-anesthesia, hypoventilation, and hypercapnia and hypoxemia. Thoracic and upper abdominal surgery can lead to VC decreases greater than 55% and FRC increases by 30%. Pain can also decrease lung volumes and increase work of breathing significantly, so pain control is of utmost importance, along with splinting to encourage deep breathing and coughing. Drugs such as cimetidine and ranitidine are used preoperatively to increase gastric pH to prevent chance of aspiration, and post-operative hypoxemia can be treated with oxygen, including CPAP and PEEP, and atelectasis prevented with IS, early mobilization, and positive airway pressure such as EasyPAP. Pharmaceutical causes of restrictive lung function are widespread, with almost 100 drugs potentially causing adverse pulmonary reactions. These are medications that affect the ventilatory pump, ventilatory drive, or chest wall compliance. They include oxygen when given in high concentrations for more than 24 hours, antibiotics such as polymyxin, gentamicin, and kanamycin, which when given IV can cause neuromuscular blockade, and anti-inflammatory drugs such as gold and penicillamine, which can cause interstitial pneumonitis and bronchial obliterans, respectively. Cardiovascular drugs such as amiodarone can produce lesions in the lung, with patients experiencing progressive dyspnea and non-productive cough. Chemotherapeutic drugs often cause pulmonary fibrosis and pulmonary infiltrates, and patients inadvertently ingesting weed killers containing paraquat show signs of alveolar pneumonitis and fibrosing, leading to death. Muscle relaxants can result in decreased chest wall compliance and pulmonary ventilation, and illicit drugs such as cocaine, particularly in the form of crack, and heroin can cause pulmonary edema with interstitial pneumonitis and pulmonary hemorrhage. Lastly, radiation pneumonitis and fibrosis, which results from irradiation of the thorax, can cause RLD and occurs 2 to 6 months after treatment. Since irradiation of the thorax is used in Hodgkin's lymphoma and breast, lung, esophageal cancers, it is important to recognize this serious complication. Patients who have undergone bone marrow transplants and are on cytotoxic agents are at the greatest risk. Treatment includes corticosteroids for acute radiation pneumonitis, and pneumonectomy may be considered for severe unilateral radiation fibrosis. Otherwise, treatment is supportive with oxygen therapy, cough suppression, analgesics, and antibiotics being the most common medications. Prevention, of course, is the ultimate goal.